111 people. That's how many Americans died from a drug overdose yesterday. Not last year, not last month, yesterday. And the day before that, and the day before that. Every single day, for the past decade, the United States has buried more than 100 of its citizens to addiction. More than car crashes, more than gun violence, more than HIV at its peak. We were told this crisis had a beginning, a greedy pharmaceutical company, a few bad doctors, a generation that made terrible choices. But what if the story we've been told is only half true? What if the real crisis, the one hiding underneath, the one we think we know, is something far more disturbing? Stay with me, because what I'm about to show you changes everything. The official story begins here. In 1995, Purdue Pharma, a privately held pharmaceutical company owned by the Sackler family, received FDA approval for a new painkiller. They called it OxyContin. The pitch was elegant. A slow-release opioid, so controlled, so carefully engineered, that addiction was, quote, less than 1% likely. Doctors believed them. Hospitals believed them. The FDA, despite warning signs, believed them. Within 5 years, OxyContin was generating $3 billion a year. Within 10 years, America had an opioid epidemic. The first wave hit hardest in places that were already hurting rural communities, former manufacturing towns, places where the jobs had left but the pain hadn't. Miners, factory workers, veterans, people with legitimate injuries and legitimate prescriptions who woke up one day and realized they couldn't stop. Then came the second wave. When regulators finally cracked down on prescription opioids in 2010, reformulating OxyContin, restricting pill mills, millions of people who'd become dependent suddenly couldn't get their medication. So they turned to heroin, which was cheaper and available and increasingly laced with something new. Fentanyl, a synthetic opioid 50 times more potent than heroin, 100 times more potent than morphine. Originally a surgical anesthetic, now manufactured in clandestine labs, pressed into counterfeit pills, mixed into cocaine, hidden in methamphetamine in some cases, found in marijuana. The third wave, the fentanyl wave, is the one we're in now. And it has no historical precedent. That's the official story. And it's not wrong. But here's where it gets complicated. Because if you look closely at the data, if you ask the questions that nobody in the official story wants to answer, something doesn't add up. Ask yourself, how does that happen? How does one country, with 4% of the global population, end up consuming the vast majority of the world's most addictive painkillers? The answer, it turns out, involves a lobbying infrastructure so sophisticated, so entrenched, that it effectively rewrote the medical standards for pain treatment not just in America, but globally. In the 1980s, a small but influential group of pain specialists began arguing that doctors were morally obligated to treat pain more aggressively, that opioids, when used for legitimate pain, carried minimal addiction risk. This idea, sometimes called the pain as the fifth vital sign movement, was championed by medical organizations, and it was funded, at least in part, by pharmaceutical companies. By the mid-1990s, it had become orthodoxy. But wait. The primary study cited to justify the less than 1% addiction claim. It was a letter to the editor, published in 1980, 5 sentences long, based on a sample of hospitalized patients, not chronic pain patients, who were monitored while receiving opioids. That letter was cited nearly 600 times before researchers began questioning whether it proved anything at all. Here's the anomaly that should have triggered alarm bells years earlier. Between 2006 and 2012, drug distributors shipped 780 million oxycodone and hydrocodone pills to West Virginia alone. West Virginia, a state with fewer than 2 million people. In Mingo County, population 25,000. Pharmacies received more than 20 million prescription pain pills in just 3 years. That is 800 pills for every man, woman, and child in the county, every single year. Either there was an extraordinary concentration of pain in rural Appalachia that the rest of the country didn't have, or something had gone catastrophically wrong with the distribution system. Under the Controlled Substances Act, drug distributors are legally required to flag and report suspicious orders, unusually large shipments, orders that deviate from normal patterns. The Drug Enforcement Administration has the power to freeze shipments and suspend licenses. The question, and this is where the story gets uncomfortable, is why they didn't. In 2012, congressional investigators found that the DEA's Diversion Control Division had been systematically underfunded and understaffed for years. Industry lobbying had consistently pushed back against tighter reporting requirements. And in 2016, at the height of the opioid crisis, Congress passed the Ensuring Patient Access and Effective Drug Enforcement Act. It stripped the DEA of its most powerful tool, the ability to immediately suspend drug shipments without giving companies advance notice. It was passed unanimously, largely written with the help of pharmaceutical industry lobbyists. Then the picture shifts again. Because the opioid epidemic the one pharmaceutical companies created has been joined by something the drug companies didn't make. Fentanyl isn't coming primarily from pharmaceutical plants. It's coming from chemical precursors, largely sourced from China, synthesized in labs across Mexico by cartels, and then distributed through a supply chain that has no script, no prescription, and no oversight. And cartels have learned something the pharmaceutical industry already knew. An addicted customer is the most reliable customer in the world. 379 million counterfeit pills, each one potentially lethal, each one indistinguishable to the naked eye from a legitimate prescription. And here is the detail that haunts researchers. In 2022, 6 out of every 10 fentanyl pills the DEA tested contained a potentially lethal dose. This is no longer about addiction alone. This is about a supply chain designed, whether intentionally or not, to kill. So, how do we explain what we've just seen? There are 3 serious frameworks for understanding the American substance abuse crisis, and I want to walk through all 3 honestly because each one reveals something true and each one hides something as well. The opioid epidemic is primarily a story of corporate fraud at industrial scale. Pharmaceutical companies knowingly misrepresented addiction risk, corrupted the medical establishment through strategic funding, and purchased political protection through lobbying. The solution is accountability, prosecution, civil liability, and structural reform of pharmaceutical regulation. This is the theory that has produced the most legal results. Purdue Pharma's $8 billion criminal settlement, the Sackler family's $6 billion civil payments, McKinsey's $600 million settlement for advising Purdue. It is well evidenced and legally validated. But it explains the opioid crisis of 2000 to 2015 far better than it explains the fentanyl crisis of today. Economists Ann Case and Angus Deaton argued in their landmark 2015 research that rising mortality among middle-aged white Americans from drugs, alcohol, and suicide reflects a deeper collapse of meaning, community, and economic opportunity. The drugs aren't the disease, they're a symptom. The disease is deindustrialization, wage stagnation, erosion of social fabric, and loss of the structures that once gave working-class life dignity and purpose. Compelling, and backed by substantial data, explains geographic patterns why the crisis hit hardest where manufacturing collapsed. But it doesn't fully explain why addiction is rising among college-educated Americans or why fentanyl deaths are now concentrated among Black and Hispanic men groups whose economic story doesn't fit the original deaths of despair model perfectly. The most uncomfortable theory doesn't require a conspiracy. It only requires us to observe what the incentive structures of multiple systems, pharmaceutical companies, distributors, regulators, cartels, insurance companies, criminal justice, actually produce. when they interact. When you make addiction profitable, when you underfund treatment, when you criminalize use while ignoring supply, when you allow a gray market chemical pipeline to operate with minimal interdiction, you don't need a single evil actor. You get exactly what we have. This is the theory I find most explanatorily powerful and most politically dangerous to articulate, because it implicates systems and institutions across the political spectrum. There is no clean hero. There is no single villain to arrest. There is only the question of whether we are willing to change the structures that produce the outcome. But here's the tension at the heart of all three theories. The United States spends more money treating addiction than almost any other country on Earth. It has more rehab facilities per capita than most developed nations. It has FDA-approved medications buprenorphine, methadone, naltrexone that research consistently shows are more effective than abstinence-only programs. And yet, of the 48.7 million Americans with a substance use disorder, only about 13% receive any form of treatment in a given year. Why? Because treatment is expensive, inconsistently covered by insurance, geographically unavailable in rural areas, and still, in many communities, so thoroughly stigmatized that people would rather die quietly than ask for help. The Mental Health Parity and Addiction Equity Act has been federal law since 2008. It requires insurers to cover addiction treatment at the same level as physical illness. In 2023, 15 years later, the Department of Labor found that most major insurers were still not in compliance. So, which theory explains that? All three, simultaneously. I want to show you something that almost nobody talks about. Not in the congressional hearings, not in the Netflix documentaries, not in the journalism that has admirably exposed the Sackler family and Purdue Pharma. This is the detail that, when I found it, stopped me completely. Naloxone. You may know it as Narcan. It is a drug that reverses opioid overdose. Administered within minutes of an overdose, it restores breathing. It does not get a person high. It is not addictive. It has essentially no side effects. It has been available since 1971. For most of those 50 years, you needed a prescription to get it. Think about that. The antidote to the most lethal drug crisis in American history required a prescription, meaning that the person most likely to need it, an active drug user in the middle of an overdose, was almost certainly the person least likely to have one. Between 2011 and 2014, as overdose deaths were climbing by double digits annually, multiple states debated expanding naloxone access, allowing pharmacists to dispense it without a prescription, equipping police officers with it, funding community distribution programs. In several states, those expansions were blocked. The arguments against them are worth hearing because they reveal something profound about how America has understood and misunderstood addiction. Some legislators argued that making naloxone widely available would create a moral hazard, that addicts, knowing a safety net existed, would use drugs more recklessly. There is no empirical evidence this is true. There is substantial evidence that naloxone distribution saves lives without increasing drug use. The research was available. The policy was not adopted. People died in that gap. A 2016 internal memo from the Office of National Drug Control Policy, later obtained through FOIA requests, showed that White House advisors had been briefed on evidence for naloxone expansion in 2014. The recommendation to fund wider distribution was included in a draft strategy document. It was removed before publication. The reason given in margin notes. Optics of endorsing drug use. Optics. While Americans died at the rate of 100 a day, the policy response was shaped, at least in part, by how it would look. Not whether it would work. How it would look. Since 2001, overdose deaths in America have increased by approximately 400%. In the same period, the United States has spent over $1 trillion on the war on drugs, a program initiated in 1971 that has never, in 50 years, demonstrably reduced the supply of drugs or the rate of addiction. What it has done is incarcerate more people per capita than any nation on earth, disproportionately Black and Hispanic people, for offenses that, in other countries, are treated as public health matters. I don't want to leave you with despair, because there are answers, partial, imperfect, contested but real. Portugal decriminalized personal drug use in 2001 and reinvested the money saved on incarceration into treatment and social services. Drug-related deaths fell by 80%. HIV infections among drug users fell by 95%. Oregon tried a version of this in 2020. The implementation was rocky, under-resourced, politically contested, but the principle that addiction is a health issue, not a criminal one, has not been disproven. It has been underfunded. In the United States, harm reduction programs, needle exchanges, Naloxone distribution, supervised consumption sites, fentanyl test strip distribution have demonstrated measurable reductions in death and disease wherever they've been implemented at scale. What they haven't had, in most places, is political will. Here is where I have to be honest with you. I don't know if American society will solve this. Not because the solutions don't exist. They do. Not because the money isn't there. It is. But because solving it would require accepting that addiction is not a moral failing? That the people dying in parking lots and bathroom stalls and the back seats of cars are not cautionary tales. They are people. With names. With families. With a crisis that our systems, pharmaceutical, legal, political, cultural, help to create. 111 people today. The same question I asked you at the beginning is still open. How much longer? If this raised questions for you, and it should, I'd ask you to do two things. First, leave a comment. Tell me which theory you found most convincing. Tell me what I missed. Tell me what you've seen in your own community. The comment section on this channel is a conversation, not a monologue. Second, share this video with one person who needs to understand what's actually happening, not the simplified version, not the political version, this one.